Welcome to Wellspring, Behavioral Health Transformation with me, Brian Jones. Each week I invite guests to uncover real solutions, sustainable design, community-centered planning, and next-generation recovery spaces that are transforming behavioral health care across America. And indeed, across the United States and here in Southern California, millions of people are struggling with addiction, trauma, and mental health, and they're being treated in outdated and overcrowded facilities. Places that too often make healing harder instead of easier. Now imagine treatment centers designed as sanctuary, where natural light, open space, and dignity are not afterthoughts, they're medicine. What if the very buildings that we build could be part of the cure? Because the future of healing isn't just in the mind, it's in the places we build, the light we let in, and the dignity that we restore. The Wellspring starts now. Thank you and welcome. Today I'm very honored and grateful to bring to you one of the world's foremost voices in healthcare architecture and design, Stephen Parker. Stephen, thank you for joining us today, and I'll give a little introduction that you are a rising star in behavioral health architecture, planning, development. You are an advocate, certainly a thought leader, a senior associate and behavioral healthcare planner at Stantec, one of the world's largest firms in sustainable engineering, architecture, and environmental consulting. I'm honored to be here with you because we are aligned in our mission to help forward the behavioral health field, focusing on the intersection of evidence-based design, human-centric care. And today I invite us to explore what it means to design a culture of care and how architecture can shape healing and how the spaces we build reflect the values that we hold. So Stephen, welcome. Thank you so much for joining us. How are you today?
Thank you, Brian. Fantastic day on this wintry January.
Yeah. Well, it's warm here in San Diego, and my work focuses mostly on the California marketplace, but you have had the privilege of working around the world, and so you're going to bring an international perspective today, and certainly appreciate that. I love that your philosophy and work is built on some core principles, and we're going to explore some of those core principles today. The architect as the advocate, the ability to create agency for patients in the healing environment, the idea of evidence-based design, obviously, and one of the core concepts is creating a culture of care. And so, to start us off, for those who may think of architecture and planning as just walls and windows, we want to move beyond that, and let's think about how a building can actually begin to create a culture of care for someone in crisis. So, in my role at BHSME, I often work with owners who are trying to move fast and who are balancing timelines and permitting and budgets. But what I see a lot happening is projects start off with a technical fit study and funding constraints and only try to layer in after the fact human-centric design. So kind of with this in mind, I'd love to begin with a simple question to ground our conversation. That when you hear the phrase culture of care, let's focus on this, culture of care, what does that mean to you as a designer and a thought leader and someone who's really shaping the way healing environments around the world are being planned?
Great question, Brian. It's definitely something that we struggle with throughout the design process and really look to clients to help us envision what this aspirational facility for the organization will be. So examining obviously policies and processes tells you one dimension of the story of the care that an organization, a caregiver wants to provide for those in need. And given the challenges of behavioral health environments, I think we need to go beyond that to the culture that you can craft through design, that culture of care, as you mentioned. And, policy does not stand up against culture, right? It gets eaten for breakfast every single day. How do you make it easier to make those connections and build that therapeutic alliance and actually craft the behaviors of staff to include a culture of care that allows them to listen a little bit more intently, figure out the needs of their patients before they might need them, and allow those patients to feel as if they have autonomy over their space, agency for their treatment and what will happen to them next. And that design has a role to play in shaping that relationship, informing that relationship, and ensuring that it's not a hindrance to the healing process. So that for me is a process that is really my most challenging, but my also the one I look forward to the most tackling with clients and caregivers.
That's great. I love that aspirational model and understanding how the workforce and the patient outcomes really work hand in hand. Um, so, when we think about culture of care, we're talking about the workforce, we're talking about the frontline doctors, we're talking about the immediate experience when clients walk into a building. What do you think are some of the key considerations that we need to think about early on, maybe in feasibility and site selection, or just basic best practices of starting out to have a clear vision of how to create a culture of care?
Sure. I mean, to dive into it, once we understand what the client is wanting to accomplish, as we look at different sites, who will be served here? How are they coming to the space in the building? Are they brought of their own volition? Can they walk into this facility under their own accord or with a loved one? Are they taken there by first responders? So it's a very different intake process of how they're oriented, and if they feel as if they're on display or that the assumption that they have about what will happen next to them is informed by signage or where that front door is, where they enter into the space. Does it feel dignified? It's the fact that they might be walking in or might be handcuffed or strapped down to a gurney. Very different understanding of their perception about what will happen to them in those situations. So, is it that the lighting is not set up in such a way that creates a cascade of flickering? So, if you think of a patient with epilepsy, when they're on their back and they're in their most vulnerable states, that even the ambiance of the lighting conveys to them that it is a softer space, is a healing space. The signage conveys to them that this is not for law enforcement, but for first responders, and their behaviors will change accordingly. Even the placement of a bathroom, um, if you have younger kids, pediatric settings, just when you first come in, where's the bathroom? It's those things that orient you to how hospitable a place is. If I have to be buzzed in by a receptionist to go back and take care of my most basic needs, that might sort of set the authority dynamic and just the placement and a security cord and access control, right? Of just in the reception area, right then and there. And that introduction to the building and what will happen next to them implies all kinds of behaviors for the patient and the providers looking to provide that care of how they want their relationships to be set up and not make them transactional, but make them therapeutic.
Yeah, great point. And there are so many different types of facilities, and as you said, it's hard to sort of generalize because each facility's got its own unique population, its own unique needs. As you said, like the different constraints are going to drive a lot of some of these design decisions. But um, you know, there seems to be a big movement, and I appreciate this movement away from institutional type design that prioritizes overt security above dignity in design. So, for example, the building behind you in your backdrop, what a beautiful building. It, it, it's appealing. It's got some uh, strong structure to it, but it's open air. It's got the natural lighting. That has all kinds of great impacts for the workforce, for the public stakeholders in the neighborhood, but also certainly for patient outcomes. But sort of before we get to some of those intangible return on investment ROI metrics, let's talk just a little bit more around dignity driven design. Um, Designing for dignity is a central theme that you've spoken on and I super appreciate. And I've heard this phrase that we want security to be invisible and we want dignity to be visible. I think you can appreciate that. And curious from your perspective, how do we make dignity visible in the design so that it really kind of reinforces this community of care, right? From first experience, introduction to the building, to perhaps the ongoing operations for the workforce.
Yeah, lots to explore there.
Yeah.
A lot of different contexts to consider. So dignity is something that is very much lacking in these spaces and places, right? It's a very undignified process where many of your freedoms are taken away for your own safety, maybe even the clothing on your back. So even just having a facility acknowledge that they will allow patient to launder their clothing and still use their clothing might be a sign of a process and a policy they have. But how do we situate just the laundry facility in such a way that they can take care of their own needs if they want to? They might be an individual that's unhomed and their clothing is their only worldly possessions. And so, how do they think about their belongings as one measure of dignity? Do they have space in their room for it? Can it be accommodated safely? And if your belongings don't belong, how can you belong? Right? And it's not just a chain of custody question at that point. And there's a myriad of little things, whether it's in a youth or adolescent or pediatric setting. Is there some sort of precious object that sort of connects them with home and their loved ones that makes a place that otherwise feels very sterile or foreign to them make you feel like you have a sense of place in that environment? Even just little things such as furniture selections and moving around. Recently saw a facility that couldn't afford to actually put all of the seating in all the spaces. So if you don't have a place to sit and staff are sort of telling you, hey, Timmy, you've spent 5 minutes, can you give Sally some time? Like you're creating authority dynamics simply for the moment of respite or the socialization that can occur, and you're creating an undue balance because you as the designer and the client have not sort of realized that the budget also need to account for all these other things, like FF&E and good furniture, and building in the social setting, the milieu that you will create in a dignified way. You'll create an undignified environment if those individuals don't have a place to be outside the rooms between programming, between therapy sessions. And that's unfortunate to see because so many projects are going mile a minute and trying to do a lot with the dollars they have. But thinking about that end result, where do you aspire your care culture to be? Do you want it to be managing the milieu and putting the burden of managing the milieu on the staff because you haven't designed in or budgeted it in not just aesthetically beautiful spaces, but functionally flexible ones through the arrangement of furniture, for example?
Good examples, and it also ties into the power of agency and how that relates to dignity, but also how agency plays into recovery. And it's obviously different depending on the acuity of the clientele, the acuity of the facility. But let's just talk a little bit about agency because I know that you've done some great work. And maybe you could talk about some specific examples and maybe some research around why is agency so important and how does it help dignity?
Great question. So oftentimes, as we mentioned, a lot of the freedoms that we may take for granted are just taken away for safety. But to balance safety with serenity, how to make a space that feels serene, that and makes you feel as if you have some agency over your built environment, that the space is not too hot or too cold, that you can change your lighting, you can self-regulate through the spectrum of lighting. Oftentimes, sleep is such a precious thing in these environments of care. I have a good friend with lived experience who talked about just the 15-minute bed check and the ability for her to open and close her own blinds at the doors, just not just to allow the staff to see into a space at night. So that way you're not opening the door, the light is spilling in, but also she could open the blinds and see out. And if she didn't want to have a social interaction with someone who may not be conducive to her experiences, she could choose to, wait that moment for someone to pass through. And so we think about proxemetics or the psychological safety you feel around different people, if you know them or not, if they're different gender or height, and the social density that's been well published in research. If you lower that social density, if you give people an opportunity to engage socially, and the space allows for that. They have the elbow room to do so. They're not feeling like they're compressed. Just the choice of a product on the door can give someone the ability to choose to interact or not. The width
Mm,
of a corridor can imply that while you may be having the worst time of your life, you're acknowledging that someone might have the worst time of their life, and you want to give yourself a little bit of space to deal with that. And I think that's also makes it safer for staff. If you provide agency and autonomy for the patients to take care of their everyday needs, they can get that blanket, they can get a snack, they can get water. They can control some aspects of their environment that then dictates their social interactions. It makes a world of difference if they are ready for that therapy session the next day, or
mm,
to have that consult, or to meet that loved one in a better state of mind than they did the day before because they slept well and they weren't woken up every 15 minutes a night because of the click of a lock. And
yeah,
so there are a million little things that can go into making a more dignified environment through that sense of agency.
yeah. Fascinating. And it touches on so many points around how quality design, designing for dignity, designing for agency, helps both patients, clients, and the workforce. And that,
Mhm.
that we really have to think about those two populations as working in harmony and creating spaces that support both of those populations' health and well-being.
Mhm.
And at BHSME, I often remind owners that labor accounts for more than 50% of the total operating costs, and turnover is very expensive. And the quality of your workforce has a huge impact on the quality of patient outcomes.
Mhm.
But when we have quality design, when we're bringing in just natural light, when we have design that feels good, that brings nature in, there's a huge reduction in staff absenteeism, reduction in vacancies in the workforce, and basically thoughtful planning makes a measurable difference for the operational success and for patient outcomes. And maybe you could talk a little bit about how you talk with owners about those returns on investments that aren't necessarily first order of financial bottom line, but really do play into the long-term operational sustainability. How do you approach owners to talk about that, and maybe what are some areas that you're looking at that are other intangible ROIs where you're doing some new cutting edge research?
Sure. I think the pro forma that many developers look at or other client types, what is their staffing ratio? What is the assumption? I've seen facilities that have an assumption of a 1-to-1 or
Mm,
greater, just
yeah,
given the risk profile. And, what is a worst case scenario where they just cannot staff to that degree? What is code minimum or what does their regulatory authority require? But also what's going to be the better practice that they're trying to maintain. And so is a good layout and design to avoid those blind spots and good line of sight. For a recent post-occupancy evaluation for a psychiatric emergency department, we centered most of the staff spaces, work areas around courtyards. So they got great natural light and garden space.
I see.
So the same amenities, we try to have parity for patients. We try to have parity for staff as well. Access to good light and outdoor environments. And so much so that they were such beautiful spaces. The staff came back during their off hours and off days to take care of the garden because they were that invested in it. And so if
Wow.
you want a good indicator of engagement of your staff is that they come back for the culture of care between each other, but also the space reflects the care they give to their own environment, right?
Yeah.
So I mean that speaks volumes to me. And there's a million little things where you place the showers. If you're not allowing, let's say, showering through an ensuite, and for clinical reasons you don't do that, do you place it with again good line of sight of staff, but also you set it up in such a way where when you plan out like a day in the life of a patient, but you have options to give them. You're not sort of forcing every patient to sort of shower at the same time. My toddler may not really want to shower at all, but he really needs to sometimes. But it makes a big difference at the beginning of the day or the end of the day. And if you give them that choice and you do so in a dignified space, they don't feel like they're on display, but you're also doing it so they're not queuing up. and creating that social density artificially because of the operations of the space. And therefore, adverse incidents can be avoided because you've operationalized the placement of this ideal location for the shower that's a dignified space that's easily observable by staff, but you're not creating mismanagement of the milieu through the use of and location of that. It might be more efficient to maybe stack showers together or in different locations. But if you think about that, hey, 50% of my cost is on staffing. If I can find a way to place that within good line of sight in a dignified way that avoids that social density, you avoid the much more expensive use of staff and the adverse incidents may occur because your sense of hygiene and my sense of hygiene might be very different things if we're all doing showers 15 minutes after each other. So I think that also provides the ability for patients then choose when they want to use these environments well at the same time. So those are just a couple of key examples that come to
Yeah.
mind, along with making sure the spaces aren't too long, too far away. I just saw a crisis center that's 140 feet long. That's a double loaded corridor for all the patient rooms. And we try to go 50, 75, 90 feet for visual or auditory identification of an incident.
Yeah.
As you get further away, the response time also lengthens. And then the number of steps a staff member has to take, do step studies,
Yeah.
even, and thinking about what is the day in the life of staff
Yeah.
as we go through these different operations. Because if it's a few more steps, that might be a little bit more hesitancy on the part of staff to react or provide that amenity or help that patient. If you can make it a little bit closer, if you can make it a little bit easier for them, their overall fatigue across an entire shift lower, but also you'll make it much easier for them to care for their patients the way they really want to.
Great. Love that. A day in the life of the patient and a day in the life of the staff. And I assume maybe you're doing some of that in the schematic fit studies and trying to make it work. And just goes to show that upfront planning before you move into DDs, design drawings, whatnot, and is just really critical. Do you find that you're maybe spending more and more time in schematics and upfront design charrettes with the operators and facility staff and whatnot? Is there a trend to take some more time in those initial early design charrettes?
It's definitely the place I look to focus my most impactful time because it's sort of as you get further down the process, it's harder to make changes and also to test assumptions earlier on, right? That the client may have had, that their staff may have had, that the other stakeholders. So the sooner you get that input to do those different exercises, a day in the life, trust or treasure exercises to find out where the key pain points are for
Mm,
specific stakeholders and find consensus earlier on. That's an area of high impact for me in the work I do. And I try to get up front to do that as soon as possible and spend good time there because that will make every other decision down the line reinforced with those sort of key insights as you go, setting up the mission and vision of the project through that engagement, how that manifests tactically in the drawings and through design decisions and planning. And then you always reference decisions back to those kind of key moments of durable decision making, if you will, earlier on. And I know that's not always the case with some clients, is that you have very fast timelines and tight budgets and things of that nature. But there's something to be said for taking the moment to breathe and sort of
yeah.
come together and then go to slow to go fast, right?
Yeah.
And go smooth. All of those sort of adages that, we may take for granted, but do mean a lot for a very complex process that is the design and development of these challenging environments.
That's right. There's a joke that, if we think that good design is expensive, why don't we think about how expensive bad design is? And thinking about those ROIs that are both tangible and intangible. Stantec has such a wide breadth of experience and research between the engineers and the consultants and the architects. I'm wondering what are some other rubrics or measurements of ROI that you look at? And I'm wondering, do you ever help owner operators develop their operating budgets early on to inform some of those decisions? Do you have double volume spaces that maybe cost more to heat. What's the trade-off between installing, your own solar panels versus using passive solar, or orientation of windows? What are some of the ROIs that you're looking at, and how can you help owners understand the real value of upfront planning?
Yeah, absolutely. I've been blessed to work in integrated design practices most of my career, and Stantec's a great microcosm of that. So our ecosystem is quite vast in terms of the capabilities and consultants we can bring to bear. So is it modulating, what the engineers tell me about the amount of glazing on this particular facade, given its orientation south or north, east or west, to help mitigate those loads, but also think about how do you use that well for the orientation for solar versus summer. You know, if it's north facing in certain parts of the world, then that might be very great and conducive to warming that space during the winter and then not letting it overheat in the summer. Is it also about if you are able to control down by zone these different spaces? So if you cluster a unit, not just to have one big open space of 25 beds that are all opening out into your social environment, in which case you have no natural light, then you're constantly heating and cooling that space. But if your census goes down or you have a change in your staffing ratio, you can open and close pods or segment the spaces in such a way where if you have an infection control issue, it's easier for maintenance. If you have a lower population of a certain type, you can close down a wing and get the savings in staff, or shift other resources around, or otherwise close off a part of the facility for any number of reasons, as you need to flexibly adapt a facility over time. Because it's not just a first cost investment,
Yeah,
it's a life cycle cost of the building systems, the energy it takes to supply that and maintain it, right? Making durable choices for these environments, both now and into the future. Is it the fact that even just the maintenance hatch, right? And the where that individual, that technician is going to access and maintain critical systems that isn't in a patient space, right? Not in a patient room, doesn't have access panels. It might ease maintenance long term, but also expedite it because they're not having to shut down spaces and cost you that room, cost you
yeah,
that space, and therefore the dollars it takes to get reimbursed for those services, because you're able to think more in a holistic and integrated fashion when you have sort of all of your consultants and engineers on board on the same table. We can
yeah.
all kind of kick each other underneath the desk and keep each other accountable there. I think that's been a really beautiful part of integrated practice, much like you have integrated approaches to medicine, right?
Yeah.
You want that for your building design approach as well.
That's a great summary. And as an owner's advisor, I try to bring together the best team early on so that we can really create spaces that win. We only have about a minute left, but I want to thank you today. And I want to continue our conversation online and offline. And Stephen, you're doing great work. There's a lot of work to be done. And it takes experts like us and thought leaders to keep moving this needle forward. So I thank you, I honor you, and look forward to our next opportunity to chat.
Yeah. Thanks for having me on, Brian, and especially for your first episode. And I look forward to the next ones.
Excellent. Thank you. Have a wonderful day. Talk to you soon. Thanks for listening to the Wellspring Behavioral Health Transformation with me, Brian Jones. I hope today's conversation inspired new ideas for building better spaces of healing and care with experts who are reshaping the future of behavioral health. Be sure to join me at bhsme.org to stay connected so I can help you one-on-one transform your healing facilities for your loved ones and your family who need better behavioral health care. Again, visit me at bhsme.org because together we can tap the wellspring and make a lasting impact.